Yeah, hi everybody. Pleasure to be here. Thanks for the introduction to present some of our work at this conference. I'm going to talk about precision medicine and how machine learning and computer vision can make a difference in this space. So first, my industry disclosures. I'm right now at Tempus Labs and own Tempus stock, and used to be at Google and still own Alphabet stock. Just super brief background. I've spent about 7 years at Google in machine learning and computer vision for street view images, and then moved to the medical space, first on, for a few months, diagnosing diabetic retinopathy, and then cancer diagnosis also in Google. And then about a year ago, switched to Tempus Labs. It's a precision medicine company. You can check out the website, www.tempus.com. Founded in 2015, about 1,000 employees, and we have 3 main locations right now. Chicago is the headquarters, and then the Bay Area in Redwood City, New York City, and we're also hiring. So reach out if you're interested. I'll get back to Tempus a bit later. But I mentioned precision medicine here, so what is precision medicine? If you ask Wikipedia, it's pretty much the customization of medical decisions for each individual patient, and in particular to select the optimal therapy for every patient. And as input for that, you use molecular diagnostics, imaging, and analytics. So it's essentially a data and machine learning problem. There's more to it, but I think in this context, that's what I'd like to focus on. And usually, like in most conferences I talk to these days, I talk about, I give an intro to what deep learning is. I think I can skip that here. But in contrast here, I want to talk about why we actually need precision medicine. This is statistics from a paper that was published in JAMA in 2015 about breast cancer. And it's showing you the quality of breast cancer diagnosis in a relatively large study here. And as you can see, a lot of diagnoses were actually wrong. So if you have this particular case here, atypia, which is a pre-stage of breast cancer, pathologists are 48% likely to give you the correct diagnosis. So you're more than 50% chance likely to get the wrong diagnosis. If you population adjust this whole table, you basically get to 1 out of 12 breast cancer biopsies being misdiagnosed. And this is pretty typical. This is the same for other cancer types. In prostate cancer, for instance, there's about 60% concordance rate. So this is a bit similar to what Jagadish was mentioning about every doctor has their own pretty much internal grading system. But it's even worse because even the intra-grader concordance is really low. For some of these diagnoses, if you ask the same doctor 3 months later, they get to a different conclusion, and the intragrader concordance for some of these metrics here is only 65%. So it's really bad, and that's pretty much why we need precision medicine and where machine learning can help. So if you look at the value proposition in this space of machine learning compared to other disciplines or other applications in robotics, for instance, or other industrial tasks, it's more about automation, scaling. In self-driving cars, it's a bit of a lifestyle optimization. And in medical diagnostics, the purpose is really to improve the accuracy beyond what doctors or humans can perform. And that makes it actually a different challenge, because the labels you're getting to train your models are of different challenge or different quality. When you look at robotics, for instance, for most cases, the labels are relatively easy. Self-driving cars have their own challenges as real-time and very high performance requirements, obviously, and then taking action after the perception. But when we look at medical diagnostics, the labels are just nasty, they're messy. That's exactly what the table before was showing you, right? It's pretty much garbage in, garbage out. We're trying to solve a problem where doctors are not good at making diagnosis, but at the same time, you're using those diagnoses as labels. To illustrate this, if you look at, let's say, a street view scene, these things can be relatively easily labeled as, electricity post, building, shop, even as categories, by just every single layman, right? And that's pretty much what you have in ImageNet. So if you're coming out of grad school, you work in computer vision, you're handed a data set which pristine labels, lucky you, that's not the real world. In the medical space, you're looking at images that are very difficult to diagnose. In this particular case, we're looking at a prostate cancer biopsy. And if you ask experts, these are doctors who have gone a decade to med school and residency, what grade is this cancer based on the common, what's called Gleason grading scheme here, which is shown on the right, they usually disagree. In this particular case, the concordance, as I cited earlier, is about 60%. So 1 out of 3 will not disagree with the rest. And the question is, which one is actually right? And when you're thinking about to train a machine learning model to solve this task better, you actually have to face a bit of a chicken and egg problem. What is your ground truth? So you have multiple options. You can use a consensus, so basically just a majority vote, let's say, and you say, okay, this is a Gleason 3, and use that as your model input. Or you can use the average and say it's a 3.33. Or maybe you can use just a vector training label and say it's 343 based on these three inputs. Or you use adjudication and ask someone who writes the books about prostate cancer, and they might tell you that there's a pre-preformed subpattern of Gleason 4 that is actually prone to misclassification as a Gleason 3. If you're very lucky, one of these experts, after you're unlucky and are diagnosed with cancer, will actually look at your case and give you the diagnosis. Most of the cases, though, you will be stuck with these highly educated people who still make wrong diagnoses. And even the experts here, as I'll show you later, are not right all the time. So this is just a really, really challenging problem, and that's actually a bit of a downer here for folks who are excited about machine learning. This is actually the main challenge in bringing machine learning to medical diagnostics these days. It's not whether you use ResNet or Inception or something. That's a tiny difference compared to getting this thing right. It's also interesting from the machine learning side. So again, we're hiring, so don't worry. But I want to talk about some applications here of machine learning in this space. So first, I'd like to talk about metastasis detection in breast cancer. A bit background here, how these images actually come to life. When you have a positive screening, let's say from mammography, then a tissue sample is extracted with a needle or with a small surgery. And then that tissue is put on a glass slide, prepared with some chemicals, so it's fixated and then stained in like these pink and purple colors. And then it's, in the traditional world, pathologists use a microscope, so really just an optical microscope, to look at the tissue, just a visual inspection. And then as a result of that inspection, they say, oh, this is cancer, this is not cancer, and this is a cancer grade if it's cancer. And that's exactly the key determinant for administering treatment or making the treatment decision. So this is a key step. Right? As I said, it's actually often wrong. Nowadays, the world is trying to move to digital pathology. Special scanners are being used to digitize these glass slides into what ends up as a gigapixel image. So here's basically a more detailed illustration of this particular example. We have a lymph node biopsy in this case, which is usually the first place in the body where a breast cancer metastasizes to, and then from the lymph system it spreads into distant organs. And on the bottom there you can see pretty much the lower left half is normal tissue, and on the upper right that's a metastasis, so that's really the cancerous tissue here. And just here on the side, as a side note, as I mentioned earlier, these images are extremely large, so you also have technical challenges of dealing with them. I'm not only talking about storage, but also talking about how to handle these from a machine learning perspective. Because you usually end up with about 1,000 DSLR photos for one biopsy image. This is one example of why it's hard, actually. So when pathologists are looking at a case like this is a lymph node biopsy. Again, they're facing a vast amount of information. In this case, it's digital, but obviously the same under the microscope. But the actual metastasis, the actual tumor in this image is extremely small. It's really only these few 1,000 pixels here on the top right side, which are a tiny percentage of the overall image. And if they miss to spot this, then they might actually render a misdiagnosis. In this case, they would call it not metastatic breast cancer, even though it's metastatic. So that's one big challenge. They're really looking for the needle in the haystack. The second challenge is that there's a lot of very high interclass similarity. So on the right side here, there's a cancer region. So this is cancer in a lymph node. And on the left side, there's benign tissue. And if you're like me, you wouldn't be able to tell the difference. Pathologists can, fortunately, but again, they make mistakes. And that's one of the reasons why, because it looks so similar. So back to using machine learning for this. What we've done, and this is a very, very common approach in this field, you basically just slice up the image, again, because it's a gigapixel image, into small tiles. And then for each tile, you obtain a label. And this is where I'm cheating, because I just told you 10 minutes ago that labels are messy, so we can talk about it afterwards, what we happen to do here. Teaser this, we basically used adjudication for this. To basically get a ground truth mask here, and then for each of these small tiles, we had a label, sorry, whether this was cancer or not, and then trained an inception network to to learn that cancer. And afterwards, doing inference, we could just stitch these back together and get a heat map of where the cancer is localized. Fairly straightforward once you have the data. And in this particular anecdotal example here of the high interclass similarity, the model was actually able to detect the cancer with very high confidence and have very low confusion in this area here. What's going on here is these are macrophages, so they look a bit like tumor cells, but not really too much. So the confusion is pretty low here and way below the tumor threshold. If you quantify this a bit more, then over a relatively large training set and test set, our results were significantly outperforming a single pathologist if they're given infinite time to do this task, which is obviously not a real clinical setting. And then this was compared to data from a public challenge, a chameleon challenge, 2016, and the model was outperforming that as well. And an important point also, again, came up in the last talk. The model was able to generalize across other data from other clinics and other scanners, which is really important because there are very different, like white balance, other image statistics when you use different scanners or different staining protocols. And the important part for us was that we didn't want to only publish a paper, but actually also make a difference in patient treatment and patient outcome. So we tested whether we can include this or integrate this algorithm, this machine learning model, into an image viewer which pathologists are using to render their diagnosis, and then measure whether it actually makes a difference in their accuracy and their efficiency of the diagnosis. And long story short, it did. So what's shown here is the unassisted view on the left. So it's pretty much in 3 levels of magnification. This is the entire biopsy image, and then here zoomed in a bit more, and here zoomed in into the cellular level, where there's actually metastasis over here. And that's pretty much the workflow pathologists would be using in a digital setting. They screen on the image and then zoom in to higher power into, let's say, suspicious regions, and then locally confirm whether it's metastasis. In our viewer here, we integrated the output of the model as actually not as a heat map, but really just as outlining where the likely tumor areas are, and highlighted it to the pathologists. And using that, we did a proper mini trial with, I think, 6 pathologists and 70 cases with washout period and everything. And then we measured that the accuracy with the model was actually significantly higher than without the model. And it reduced the error rate by 1/3, which is pretty significant, given that we're already in a relatively high accuracy over here. And the reason that this is high accuracy to begin with is because it's not such a challenging task as the prostate cancer grading that I talked about before. It was also more efficient, so pathologists were essentially faster to find micrometastasis than they were without these augmentations. So it was also very promising, and the work is published in a paper here in AJSP, in case you're interested in more details. Separately, because of the adoption challenges digital pathology is facing, we also try to integrate this machine learning model into an optical microscope. Because in reality, more than like 95% of pathology is still being done in the microscope, because it's still superior in terms of the optical quality. It's more accessible, it's a more natural workflow, etc., etc., etc. Digital pathology has huge advantages, but it's just not there yet. So what we did, we took a regular microscope, clinical microscope, had a camera on it, and then we're using a video feed from the camera and using that as input to our CNN with a GPU. This was using the same model that we trained on digital pathology images. It computed tumor probabilities into a heat map or an overlay, and then we projected that using a microdisplay into the optical pathway. And this part was extremely important because we didn't want to digitize the image and then show pretty much a VR view, but to really show the optical view because of the superiority of optical imaging compared to digitization, and also because the regulatory situation of this device would be easier in that case. So we got this augmented reality microscope and had some user experiments with it, and it turned out to be, I think, pretty promising. This is how it looks like. It looks like a bit like a Frankenstein's microscope, but it's pretty much the path I described. So this is the view by the user, and they end up seeing an overlay of the tissue image and the algorithm's output. And the key point was that this has to be in real time. So when they're moving the slide around, they obviously don't want to wait for the output. So this is a kind of earlier result that this work had at Google about, I think this might be about 1.5 years ago. Nowadays it's actually even faster, the latency is much reduced. In case you're interested, I don't have the full video here. There's a YouTube video, if you just Google for Google Cancer Microscope on YouTube, which shows this device in action. And the beauty of it is it's actually it's a platform that's relatively agnostic to the specific application. So the hardware is a component that's independent of the software controller, and the software controller is independent of the machine learning model. So we use it here for breast cancer and prostate cancer diagnosis. But if you have anything else, like colon cancer or immunohistochemistry quantification or something, you can also just download or upload essentially a TensorFlow network to that architecture and then run it. And so second topic I want to get to, which is a bit more complicated from the machine learning or definitely from the label side also, is on prostate cancer Gleason grading. So this is what I mentioned earlier, it's a very subjective task to essentially assign a discrete number to a continuous morphological spectrum in biology. So pathologists are looking at this, and instead of saying there's cancer, yes or no, they say there's cancer and it is of pattern 1, 2, 3, 4, 5. And 5 usually means like really bad, poorly differentiated, high aggressive tumor, means it usually gets resected very shortly. Whereas the more benign versions are usually watchful waiting. So again, really important part in the decision making for the treatment to get this right. So this was also work from my group at Google, where we used a bit more than 1,000 slides. And again, keep in mind, each of these is gigapixels. So it's actually a lot of data. And we had literally an army of pathologists to label it. And that's where the ground truth problem comes in. So we did rely on one single pathologist label here, but we used a framework where we had 3 pathologists label each case, and in each image also on the segmentation side. And if there was any disagreement between them, we had that go through an expert. So pretty labor intensive, not really scalable, but it was a proof of concept work. And then we had these GU experts, to really determine ground truth if there was any ambiguous labels. The model architecture was pretty much the same as in the metastatic breast cancer. The only difference here, so we basically just used a sliding window of inception to make a local inference of what pattern this is, using the labels that we obtained from the pathologists. And then there was the second step, and that's pretty much the difference, where we were basically summarizing what's on the slide to map it to the clinical diagnostic rate, because the way this is graded is actually, it's using essentially a quantification of the different patterns on the slide to arrive at the final diagnostic level. Pretty much same thing, like when you actually have trained the model, you run it, you get a heat map, and from the heat map, you infer the so-called grade group of 1, 2, 3, 4, 5, or 1, 2, 3, 4 to 5. The result of this, and this was published earlier last year also, was that we obtained superhuman performance. So superhuman here means it's better than a general pathologist. So we had a pretty large cohort of 29 general pathologists grading the same cases. And the ground truth here against this was measured was the prostate experts. And taking that as ground truth, our model had an accuracy of about, I think 69% or so, and the general pathologist had 61%, which is pretty promising, right? It's nice. I mean, if I had prostate cancer, I would rather have this model diagnose it than general pathologists. But one thing we learned from the previous study with the metastatic breast cancer is the machine learning is actually not better than a human. It has to be used in conjunction with a human. I think I failed to emphasize that in that section. What we observed there is that an augmented intelligence setting is pretty much the way to go, because when we only used the model, you basically had a lot of false positives. You had very high sensitivity. Obviously you can tune it, but the best overall performance was if you use the model to detect the potential needles in the haystack. And then you have the pathologist who reviews the, let's say, 10 most likely needles that you point out, and then confirms which one is really cancer or not. So you get the specificity and the context and the deeper domain knowledge from the pathologist, but the screening and the high sensitivity from the model. And it's actually similar here that you need pathologists to take the entire case context into account to render a diagnosis. But the pretty mundane task of detecting the patterns and quantifying them, that's what the model can do much better, and that's what we measured here. As I said earlier, experts are also not really perfect, partly because the grading system here is actually ill-defined by itself. So we also measured survival or outcome as ground truth, and did a risk stratification with the model, basically into high-risk patients. This is a Kaplan-Meier curve, so you want to be on this arm, which lives longer. These are the more aggressive patients. And the risk stratification here basically tells you, it tries to discriminate between low-risk and high-risk patients. And you want as high as possible separation between these curves to show that whatever is making that diagnosis is a good discriminator for aggressive versus non-aggressive. And our model here is shown in, I think in red. So it had a higher risk stratification or better risk stratification than general pathologists, and a lower than the prostate experts. So in other words, the people who write books about prostate cancer were still better than the model here, but the model of the deep neural network was better than general pathologists. And that's a trend that we see in many of these applications, that if someone is extremely well trained on it, they can still outperform the neural network. But if you're basically dealing with a standard expert, the standard pathologist, then you're already outperforming it. Another very nice side observation that I mentioned here, that we found here related to something I mentioned earlier, is that the model was able to put the continuum again into a discrete spectrum. So what's shown here in these dots on these circles is for each of these groups of cases, how many pathologists agreed on which case, on what grade. So in this case here, for instance, 3, 3, 4 means 2 pathologists said it's a 3, 1 said it's a 4. Over here, 1 said it's a 4, 2 said it's a 5. If you look at the softmax output of the model for those cases, it actually captures the distribution very well. So for a case, or for one particular instance in an image, it tells you whether this is between a Gleason 3 pattern and a Gleason 4 pattern, or between a Gleason 4 pattern and a Gleason 5 pattern. So in other words, you can make that discrete spectrum continuous again, just like that's shown here, and map the known grades onto this more continuous spectrum, and also try to identify morphology that correlates with the grades in between, in the expectation of that also having a more precise prognostic value for treatment or for survival of these patients. So that's really, I think, one of the key promising areas of machine learning, that we can not only recapitulate what doctors are doing in these human-crafted systems, but we can go beyond it and potentially detect new patterns, and also get beyond the limitations of the existing systems. And that's pretty much what gets me to Tempus. So this previous work was all from Google, partly because we haven't published much of our work at Tempus yet, but stay tuned. So beyond diagnosis. So what we really want to do is to take a more comprehensive view of a patient and look not only at the image or the pathology images or radiology images, we also want to look at their genetic predisposition. We want to look at their mutations, their RNA expressions. We want to look at the clinical history, like smoking status is a trivial example, but also what medications were they on before, how did they react to those, and use all of the data as input to a model that can eventually predict therapy response and identify, back to the precision medicine dream, the best treatment for every patient. And back to the survival curve here, wouldn't it be awesome if we could just train a model on survival directly and skip this whole mess of Gleason grades, which were invented by the 60s based on a few hundred cases? It would, right? And for that, we need a lot of data. We need a lot of data for various reasons. If you look at pathology, for instance, you basically have one label. If you go to an outcome-based model, you have one label for each slide, or even for each set of slides, right? Because each case consists of 10, 20 different images. And in the diagnostic setting, where you try to recap what pathologists are saying, you can somehow localize it. So you get millions of training patches for each image. Here, you get pretty much one image with one label. So long story short, you need a lot of data, and also you need multimodal data, including the sequencing results, the clinical data, and very importantly, you need this outcome data. And that's something which an army of pathologists can't give you. You need this integrated view. You need to follow the pathologist, the patient, and you need to know, like a year later, 5 years later, are they still alive? And that's extremely challenging. And that's one of the core advantages we have at Tempus. We have this integrated data. We're generating it in-house from our partner hospitals and patients who are prospectively undergoing sequencing for treatment decision. And we have this data to build these multimodal models and really train models directly on the raw data to try to predict treatment response and things like adverse events, etc. Just a tiny glimpse of what we're doing in this space that I can disclose. This is a segmentation of slides, of a pathology slide again, where we're looking at spatial features in it, like immune cells in particular, and just pay attention for that in the interest of time. So here is the magnified view where we identify where's the tumor, so that's here in blue, and then where are immune cells in red. And this is extremely important for treatment response, in particular for immunotherapy, because this allows you to quantify how to characterize the microenvironment of a tumor and determine in which of the different settings it falls. So it can be immune desert, where there's no immune cells over there. It can be immune excluded, where immune cells are there, but they can't penetrate into the tumor, or it's immune infiltrated. And these different settings have very different implications for the efficacy of immunotherapy. So being able to measure that, and then also bring the molecular database into it. Like we can actually sequence these parts here and identify what exact cells it is and what molecular variants are present in the tumor. All the information what allows us to make, hopefully at some point, really accurate treatment predictions and find the right treatment for every patient. So with that, I'd like to thank a bunch of people at Google and at Tempus, and mention again that we are hiring. We are pretty heavily hiring data science and machine learning here in San Francisco, in the Redwood City, to be specific. So if you're interested, just drop me an email or check out our website. Thank you.
Thank you, Martin. All right, we have time for a question or two. Anyone have any questions? I'd like to ask one question, actually. So it seems like adding ML training with standard pathologists get you really good answers, as if you had the expert who writes the books. Do you think that's going to alter the way medical schools now train pathologists? Like, it's okay not to be the most expert, just make sure you have your ML models at your side. How does this affect kind of the way MDs are going to be operating in the future? How do you think?
That's a really great question. I hope it doesn't lower the quality of medical education, but at the same time, I think it's just the fact that doctors are getting more used to the mindset of having tools at their disposal that are more powerful than just a regular microscope or just a stain. I think there are some examples out there already where even like for simple tasks like quantification or so, they start to rely on a machine learning model to count, let's say, cells or so, as opposed to estimating it. So I think in terms of the education, it should shift to a very technology-friendly approach where doctors are using these tools not to replace them, but just use them in an augmented way.
That's right. Very good. Well, thanks again, Martin, for your talk.
Thank you.
Bye.